Thank you, David. And it's an absolute joy and privilege to be here today with so many folks who I've gotten to know over the last 10 or 15 years working on this issue, and so many new faces to get to meet. I will also say it's a delight to be here in person rather than virtual. Thank you to Northwell for making this happen. So as Dr. Zhao just outlined, really the public health approach to firearm injury relies on 4 basic steps, right? The first is having data about who is hurt, who dies, and what happens to them after folks have been exposed to a bullet. The second step is to identify risk factors and protective factors, all other things being equal, what puts someone at risk or helps protect them from being shot and from the after effects of a bullet. The third step is to develop and test interventions like Nina and Fatima talked about. And then the last is to disseminate them, which of course is the ultimate goal of this panel. But as Dr. Zhao outlined, we are unbelievably limited because the data that we have, thanks in part to those 23 years of limited federal funding for research, thanks in part to some continued federal policies that limit our ability to track firearm injury data. The ATF report, that trafficking report, was tremendous, but is just the tip of the iceberg of what we need to know. And thanks in part to fear about collecting data, we know so little about the scope of this epidemic or its after effects. So today in this panel, I'm thrilled that we're going to get to talk a little bit about data, the foundation for the public health approach, both where we see continued deficits and where we see opportunities. I am joined today by 3 tremendous co-panelists. I will let you each introduce yourselves very briefly, but we have Fatima Parekh, who's the SVP and Chief Health Officer for Salesforce. We have Chris Jones down at the end, who is a captain of the U.S. Health Service and the director of the Center for Injury Prevention and Control at CDC. Thank you for leading NCIPC, thrilled. And Rosanna Ander, who is the founding executive director of the Crime Lab at University of Chicago. I'm going to ask you each to start by briefly introducing yourselves, and instead of starting with a deficit mindset, I'm going to take a page from Michael Dowling and start with an optimistic mindset. We hear a lot about what data we don't collect on suicide, homicide, domestic violence, injuries. I'd love to hear about what data do you feel from each of your perspectives we're good at collecting right now. And Chris, I will start with you.
Well, thanks very much.
Brief intro, and yeah, go ahead.
Chris Jones, Injury Center Director at CDC. Really appreciate the opportunity to be here today. And as you mentioned, Megan, I mean, data are foundational to all that we do in the Injury Center and at CDC and public health more broadly. And I think for us, we have really tried to take a thoughtful stock of where are we with data. One, timeliness of data, the specificity of data, where are the gaps in data. I think that from a positive framing, we have made progress in making mortality data more timely. We have provisional data now for overdose deaths, for homicide, for suicide, for injury topics on CDC Wonder, which is a point-and-click system that to me was a really important step forward. That you basically had to wait in prior years, 12 months, 18 months, some years, 2 years, 3 years to get mortality data. And then you would see this burst of activity. And now there is continuously updating of provisional data with about a 6 to 7 month lag, depending on the particular outcome. For homicide, for firearm, suicide, firearm, homicide, it's about 6 months. So we are able to see things in much quicker time for mortality than we used to, but you also have the very rich demographic data as well, which to use those data to understand geographically what's happening, where is risk changing. So I think that's one area where we've made improvements. Could it be better? Absolutely. The medical examiner coroner system is overburdened, it is challenged. Certification of deaths like homicides and suicides take time. We're often compared to the COVID environment where sort of like, well, we know how many people died from COVID yesterday. How come we don't know that for firearm-related deaths? And it's just more complicated. As soon as CDC gets the data from medical examiners and coroners, we turn it around very quickly. But we also need to make sure that we're supporting medical examiners and coroners to do the very critical work that they have to do. So I think we've made progress there. And then I don't want to take up all the time. I think the other area where we've made progress is with our syndromic data. This is taking data systems that were originally set up to capture bioterrorism or chemical or radiation nuclear events and leveraging near real-time emergency department data to identify what is going on. And typically at a national level, we're getting those data 48, 72 hours. In the firearms space in particular, we've funded 10 states over the last couple of years to specifically leverage this data system to identify in more near real time what is going on in the community, but not to have it just for the sake of having it, but to really bring people together to talk about this is what's happening in our backyard. We need to bring solutions and using data to drive that conversation. So I think, again, in that area, there is more that can be done. We still need to improve our ability to disentangle firearm-related ED visits. Was it because of an intentional event, suicide, homicide? Was it an unintentional exposure? Those are some of the challenges that we have. We need better capture of race ethnicity data in the syndromic data, but it is a newer resource that people are using to drive action in communities where, even in states like Georgia where I live, they created a dashboard using funding through our FASTER program and are bringing people together to do that. So it is, I think, an important data source and an advancement that, several years ago we didn't have that, and now we do. But I'll say, as a researcher, we have lots of data challenges. So even though we've made progress, we still have a ways to go.
Thank you. And I'll say that the FASTER surveillance has been tremendous. So for those that aren't familiar, like you said, it's the same system that we use to track, say, norovirus outbreaks or influenza-like illness is now being applied to injury, which has been just tremendous. So thank you. Rosanna, how about you? What's your optimistic take on data?
First, I want to say thank you again to Northwell. This is incredible to be in this room. I have been in this issue for a very long time. I can remember the early days with Jim Mercy, Mark Rosenberg, and others when it was a new thing to even call gun violence a public health issue, and it is so heartening to be here with so many believers and doers. It does make me optimistic. I run the University of Chicago Crime Lab, so we're an independent research organization based at the University of Chicago, and a lot of our work is really at the local level, and where I feel optimistic, or where I think there's tremendous potential in the short run, is to get municipal data from police departments, from health systems, to be actionable. It is not, it is the public's data. Fundamentally, we need to be able to unleash that, to be able to help community violence organizations or other nonprofits that are working in the space, or other parts of government make decisions based on where the needs are, and that local data it's imperfect, but it still is an unbelievably valuable tool. And my team actually built a violence reduction dashboard for the city of Chicago. It sits on the city of Chicago's servers, and it was co-designed with community violence organizations, telling us what they need, what way do they want the data presented, and that is near real time, as in basically 48 hours after an incident. It's pretty robust, and hopefully we can share that website out, but that information is timely and important for people who are making decisions about where to deploy resources in the moment. I think we have a long way to go at the federal level. The fact that we don't even have accurate counts of non-fatal gunshot injuries is shocking in 2023. And so being able to tap into, and it really is, I think, a call to action for local levels of government to not hoard that data, to find ways to make it available and put it in the hands of practitioners, policymakers, and the public to hold our electeds accountable.
You guys have an election today in Chicago, don't you?
We do indeed.
Thank you. And Fatima, how about you, from your kind of private sector perspective, but you also come to this from an injury prevention background?
I will certainly do. Again, my background is both in general surgery and public health from a clinical perspective. I did complete a fellowship at Hopkins in injury prevention at some point. And as I think about, well, why did I make this jump onto the tech side, right? The potential is absolutely huge. It's not so much in the data that's not available, because I have a very optimistic view of the world in terms of how I look at the number of data sources that are truly available. I think the real magic happens when you can bring that data together, make it accessible, leverage the fact that it is actually very high quality in nature, and make it most usable through platforms that are scalable for a number of different types of interventions across the field. And so that's where my passion currently is, and how I think about the problem. I do think it's incredibly important to make this data most easy to use.
Well, I'm going to ask you each, you've given a couple of examples, but Fatima, I'm going to go to you to talk about some examples, I think, that of how you have worked in the private sector to find potentially new sources of firearm injury data. I think that one of the things that many of us sitting around the room have thought about is, okay, there's this deficit of data. The federal level is going to be a little challenging for a little bit of time. So how do we work kind of as individuals within this room to find those newer sources of data and to compile them? So I'll go in opposite direction this time. Fatima, if you have any examples to share.
I think for me it starts with actually making the business case. I mean, I know Michael Dowling has managed to get 50 hospital CEOs, right, and together to say we're committed. But actually it goes beyond just healthcare, right? This is a problem for everybody. It's affecting every single person out there who has a job or doesn't have a job, right? But when you think about the number of folks that receive their health insurance through employer-funded healthcare, that's about what, over 50% of the population. The majority of those are coming from self-funded plans. So there is an increased burden on how gun violence is showing up in our workplaces, and just in terms of the number of people affected, right, that are thinking about this. So when you turn it into an economic problem where every single company now becomes a healthcare company and they have a stake in this, you actually start to see that there might be some other sources of data, and that does actually exist from a payer perspective, right? Because you're able to start tracking the impact from a longitudinal perspective of gun violence on our employee populations. You play this forward a little bit, and there is definitely loss of productivity, right? There are the psychiatric complications of anybody who has been through this, in addition to the physical manifestations of injury, and that all has a very direct cost as well. That's fairly easy to capture in this day and age. And again, I think you turn it into an economic problem and a lot more people are willing to listen.
And I'll say it should be easy to capture cost and charges, but any of us who have actually tried to look at that data for firearm injury, it's quite limited both by the coding and then by the fact that so many survivors or family members go outside of the system where the trauma initially happened. So insurers really do become our best bet on that. And I'm looking around the room and know that many of you have tried to kind of take a bite at that elephant from various angles. I also want to give a shout out. GAO has done a nice report on the estimated cost of firearm injury as well. Rosanna, how about, can you give an example?
I'm going to just make a plug for another sector that really needs to be brought to the table. I'm glad that the healthcare sector is really taking up the mantle and really has been on the front lines as much or more as law enforcement without necessarily getting the credit. But I think another sector that I think is really important. So in my home city of Chicago, the average age of a gunshot victim is about 27 years old. But we don't need to wait until they're 27 years old and on either side, frankly, of that firearm. And I think the school system, the public school system, has enormously valuable early data on children who are facing barriers and challenges. And in my home city of Chicago, if you look at the children who do become victims or frankly arrested for being involved in gun violence, literally something like 95% of them are no longer actively engaged in school and don't yet have a high school diploma. So can we bring the school system in to really help work with students who are becoming disengaged so that we can ensure that they get the free public education they're entitled to, but also that we reduce the likely kind of downstream harms, including justice system involvement, but also gun violence. So figuring out ways to bring them in. And I think there are some great examples. I think there's some good work happening in Chicago and other cities, but we need to be much more intentional because none of us want to be doing this sort of after the fact. Prevention is always better if we can do it. And I think the school system is a huge part of that prevention infrastructure.
I love that, and it's a great call to us to do that upstream work. I will also mention, for those that are not familiar, the Crime Lab has done some really neat work in partnership with community groups with creating predictive models to better kind of hone in on who's highest risk of being involved in firearm injury, where you've both taken kind of the data that you've had access to from a municipal level, which includes school, LEO, hospital data, and then worked with community groups to further refine that, correct?
Yeah, basically.
Yeah. So a neat model, I think, for many of us as we're thinking about how to kind of appropriately direct resources within our own communities.
Yeah, well, I think that the examples that were raised are really important ones, and especially thinking about the upstream piece of this that, often we're sort of dealing with the data set that we have access to, and you just get just a snapshot of what's going on. So you get an emergency department visit, or you see somebody who has died, but really layering on the context, right? These things are not happening in isolation in communities. There are things that are happening in homes, in families, and other aspects of the community that are measured in different places, but they're not necessarily all brought together to tell that story. And I think in a number of our extramural research projects, researchers that we have funded are doing that. They're trying to bring data sets together or overlay data sets to really better understand the risk factors, the protective factors. What are the trajectories for risk? What happens after somebody has an event and they have a touch point with the health system? If you're just looking at claims data, you may not know what exactly that is because they may have gone somewhere else. So really trying to be thoughtful, and a lot of that is happening at a much more local level. That is very challenging from a federal perspective to have those data sets all together because they sit in different agencies. They don't have identifiers by the time they get to us. So those are things that we're trying to make progress on. But I do think there's an opportunity to really empower communities, health systems, leaders in communities to say, let's bring folks together, criminal justice, behavioral health, social, human services agencies, law enforcement, educational system, what's happening before kids get to school, how are we measuring child welfare, other aspects that we know contribute to risk for violence, that we can really start to paint the bigger picture of what are the interventions, how far upstream can we go? And I think that's where there is the real opportunity. There are things around coding that we're trying to do to improve. I know there's a lot of interest in non-fatal, and I agree that that is a challenge, and there are ongoing conversations with trying to, very much in the weeds, talk about the default settings for non-fatal ICD-10-CM coding. But that is an important piece because it does limit our ability to look at what's really going on, and we underestimate assault and tend to overestimate accidental or unintentional exposures in emergency departments. So those are macro things that we are interested in and trying to advance. But I think at a local level, there is a real opportunity to pull data together in a very rich way to help tell the story and to make the business case, but also just to make it the case that this is not happening somewhere else, that this is happening in our community, to our community, and therefore we have the responsibility to address it.
Well, we have just a minute or two left, so I'm just going to do a quick round robin for a last question of, you have this amazing audience in front of you of folks who are dedicated to combating gun violence as a public health problem. What's one thing that you would love to see each audience member kind of go home and investigate whether they can do in their own healthcare system or community organization or as part of a local group?
At the policy level, I would love to see real alignment of incentives to ensure that the data gets shared and it is truly usable. I think right now, again, we've got pockets everywhere of this amazing data, but nobody's actually bringing it together at that holistic level to really determine where best to make the intervention. So that's my one wish.
Yeah, and I would say it's really, really important to disaggregate the data. I think people talk a lot about equity, but if you look at trends at the state level, at the city level, you're going to miss really important disparities in impacts. And so really finding ways to disaggregate the data so that you can target resources where they're most needed and hopefully can do the most good.
I love it.
Yeah, I would say, I think just looking for opportunities to create new partnerships. Who's at the table that's not at the table? That needs to be there, I think is really, really important. That will help with data, that will help with policy, but how do we broaden the conversation by bringing in people who are on the fence or who are so far behind the fence they don't want to be a part of the conversation? I don't think that we can really make progress until we really think about having everybody at the table, even if there are differences of opinion. We've got to work through those issues and find common ground because there are solutions that can be brought to bear, and we need to make every effort to implement them.
I love that, thank you. Well, I'm going to say, if you think about how we've combated surgical infections, how we are creating dashboards to identify places to dedicate resources for opioid overdose, it all starts with having accurate measurement data. And so I think if you take nothing else away from this panel, my hope is that you take away a commitment to making sure that the data from your system is accurately coded. Some states don't require external cause of injury codes. Make sure that that coding does get into your billing database. Think about ways to share it. think about ways to partner, whether with law enforcement, schools, or most importantly, our community groups, making sure that the public health is truly based in the public. And then my last request would be to think about those longitudinal outcomes. How do we combine forces to look at what happens after someone is exposed to a bullet? So a huge thank you to the three of you for your leadership in this work on data, and thanks again to the entire community for being here, and to those online. I look forward to next steps together, and to hopefully coming back in a year and having some great data presentations that we can display. One last call out is I will say for municipalities that are working in this area, Chicago, Philly, I know there are a couple of others as well that are creating dashboards. It would be wonderful for us to kind of collate and share those to serve as exemplars for those of you that do want to work with your local mayor's offices or counties. So thank you.